Now, I'm going to introduce now our keynote speaker, and that is Professor Jeff Lazarus. And he's got a very extensive, broad CV, and I'll just give you some of the highlights of his CV. He's Professor of Global Health at the City University of New York. He holds a position as a research professor at the Barcelona Institute. He's as an affiliated professor at the University of Copenhagen World Health. He's involved as a principal investigator of more than 10 active liver research projects and is the author of more than 400 peer-reviewed publications. He's on the editorial board of Journal of Hepatology and Liver International, and in 2023 was awarded the American Liver Foundation Distinguished Scientist Achievement Award. Today's meeting is structured around an article that Professor Lazarus principally authored, and that is entitled A Global Action Agenda for Turning the Tide on Fatty Liver Disease. So I'll now hand over to Professor Lazarus. Thank you.
Well, thank you very much for that warm introduction, and hello everyone, good morning. As you might be able to see, although there's a bright light shining on me, it's dark and evening here in New York City, and I'm sorry not to be able to join you, because I think the symposium format is really nice compared to some of the scientific meetings where it's just a straight sort of lecture and death by PowerPoint. I will try not to bore you to death, but instead take you sort of through, how I've worked with, as the introducer said, MASLD, NAFLD, NASH, MASH, steatotic liver disease, and so on. And to the moderator, if I don't see your colors, please just shout out when I have about 5 minutes to go. I have a lot of photos at the end, so I can take them slower or faster, but I want to tell a particular policy story when I wind up. And I've titled this talk, Low Awareness of MASLD MASH and the Need for Public Policies and to Expand the Community of Practice, which I'll explain. But in a nutshell, I think we have a bottom-up approach, which is really what we're all doing, but things will really change when we start to have the right policies in place, including from the World Health Organization and the United Nations. And I'll conclude with some of the efforts that are being done at that level. But firstly, the terminology. So I coordinated the methodology for the new nomenclature that was published in 3 leading society journals at the EASL, the European Association for the Study of the Liver Congress in June 2023. And as you can see on the left here, we have MASLD, which is the consensus name. And we realize that when we talk to lay people, which is almost everyone, will say fatty liver disease. But because of some perceived stigma, it's important to be able to go home and say, I have MASLD, or I have a serious liver disease, or I have metabolic dysfunction associated with steatotic liver disease, without mentioning alcohol and without mentioning fat in the name. That was really the ask of patients and others with lived experience. And on the right, under this continuum of steatotic liver disease, we include alcohol-related liver disease, but since some people have MASLD, some people are drinking more than the sort of the allowed intake to be defined as what was then NAFLD or now MASLD. There's a new disease category, which is MET-ALD. And I think a lot of people will be diagnosed in that category as we start to get a handle on that and as we start to get, a more accurate understanding of how much people are actually drinking per week. So I don't want to dwell for a long time on this, but this was a huge multi-year process, a global effort led by leading societies. And while everyone doesn't agree on the new nomenclature, this now has almost 2,500 citations and is being used by most of the leading societies around the world. And I think too much public debate, I'm a fan of public debate, but too much public debate at this point is becoming counterproductive and creating some confusion in the field. So I appreciate that you're calling your symposium MASLD. And the MASLD, diagnostic criteria are really that, you have steatosis and, one or more of these confirmed or suspected cardiometabolic conditions. diabetes, central obesity, hypertension, and metabolic dyslipidemia. So really confirmed or suspected steatosis, and then a confirmation of one of these four conditions. Then you have MASLD. And so just to, not to belabor the point, but to say a few words about the nomenclature, this was an issue that was raised by the patients who wanted a disease name that was easily understandable, would reduce or avoid stigma, and also had a recognition of multi-morbidity, thinking of, MASLD as the hepatic manifestation of metabolic syndrome. So we wanted to get metabolic into the name. Medical experts wanted a name that was more accurate and precise with clear defining characteristics, and that would help us start to refine our clinical care pathways and the kinds of MDTs or multidisciplinary teams that would be, most fit for purpose for addressing this condition or this set of conditions. We wanted to be able to raise awareness to policymakers, so that they could really understand what this is and that it's not just a liver disease, but it's really, a disease where we're going to have comorbidities at the same time. So the good news is we're often treating, some of those comorbidities. The bad news is that we have, multiple conditions in one person at the same time. And most often the liver disease is being ignored. And I appreciated the speaker who spoke in the introduction about, lived experience. And I'm going to come back to that in a little bit. And finally, the societal perception is to not marginalize or stigmatize people. Liver is really a stigmatized organ. These are stigmatized diseases. And I think, by being able to say, metabolic dysfunction is very helpful, or simply use the abbreviation MASLD. We do that all the time with disease names. So we don't always need to spell it out anyway, as long as we understand what it's about. And so the steps now are to have unity in the field and to start to engage with other related fields, particularly endocrinology, given the high number of people with type 2 diabetes who have MASLD, MASH, and liver fibrosis. Also engage with primary care and cardiology, all of that in an effort to expand the community of practice. So I don't know exactly who's in the room, but often, the only people in the room are the liver experts, primarily in the upper left, hepatologists and gastroenterologists. But we need to be engaging with nutritionists and dietitians, but also associated NGOs, industry, beyond pharmaceutical companies and diagnostics, but also digital health groups, med tech, and others, and really take a community approach. I look at other disease areas where I've worked earlier, viral hepatitis and HIV, where the community has really led the way. And that's not what we're seeing with MASLD, MASH. It's a few liver specialists and not really anyone else giving attention to this. And finally, the research committee needs to go beyond, a community needs to go beyond liver health and engage with public health and global health. Some of you might have seen, the Global Health 2050 Lancet Commission that was launched at the World Health Summit last week. And if you search for, MASLD, MASH, really liver disease, you're not going to find anything. So in the priorities for 2030 in the Sustainable Development Goals, we don't have MASLD and MASH mentioned. And in the new 2050 targets, we don't have MASLD and MASH mentioned. So we really need to work with adjacent fields and bigger fields like public and global health to make sure this issue is not left behind. And that means going beyond a liver gut focus and looking at how we can evolve the field and challenge some of the obesity and steatotic liver disease paradigms. So the concrete disciplines, are those I mentioned, nutrition and primary care and endocrinology, but also obesity medicine, behavioral psychology, because of all of the stigma related to body image, related to the liver, and also cardiology. The majority of people with MASLD will die of cardiovascular disease. But when I look at preventive hepatology programs, you have nary a mention again of MASLD and MASH. And this isn't because I'm a single disease advocate, but it just surprises me how we're able to deal with public health, global health, even heart health, and not mention a disease that's estimated to affect 1 in 3 adults over the age of 20. And here you can see some of the estimates, growing every year, the data is not super strong, but I mean, if you even with the confidence intervals, we're looking at 33 to 42% estimated adult prevalence. And I included people living with HIV here because one thing is the adult prevalence. We also need to know the prevalence in groups that are in our care. And I know in Australia, you have a great program to identify and link to care people living with HIV. So why not also test them, for liver fibrosis? And the same can be said about so many other conditions. In this case, we did a systematic review and found, again, the same number, around 1 in 3 people living with HIV have MASLD. They're mostly in our care and on antiretroviral therapy, seeing specialists regularly, and the majority of them, have no idea that they have, excess fat in the liver. So the question, that you can be thinking about in your discussions is what's the MASLD and MASH prevalence in Australia, in your country? What data is it based on? Because data is incredibly important when we advocate to policymakers. Likewise, with obesity, there is lean MASH as well, and maybe 10% and even higher in Asia will present with lean MASH, but still there's a close relationship with obesity. So as we see those rates go up, and they're already very high, including in Australia, it also begs the question of, do we know the prevalence of overweight, and obesity in your country and in your city, and are there programs to test these people with simple tests like the FIB4, which is a sort of a serum biomarker based on 4 components: AST, ALT, platelets, and age. Really easy to do, done on a free calculator, and it gives you a pretty good idea of if the person will have liver fibrosis or not. But are we doing this for those people who are at risk? In terms of expanding the community of practice, when I read about obesity, I read about the mechanical complications, the behavioral and mental health complications. And when I read about the metabolic complications, I rarely see MASLD. So it was great to see in this Lancet seminar just a few months ago that they include MASLD where it should be, along with type 2 diabetes, hypertension, cardiovascular disease, diseases that disproportionately affect people who are overweight or obese. So one thing is from the liver field advocating, but another is to start to see our colleagues making mention of this highly prevalent disease. And speaking of high prevalence, the global MASLD prevalence in people living with type 2 diabetes is around 2 out of every 3 people living with diabetes, around 62%, around a third have MASH, and around 17% have advanced fibrosis. So those are very high numbers, and it begs the question of, are we testing this population for liver disease? And the answer is typically no. And we can have a discussion about that, why endocrinologists are so reticent to test for liver fibrosis, with people saying there's nothing we can do, or we wouldn't do anything differently. And I think in terms of prevention and in terms of patient rights, people have a right to know that they have this disease. And we know from some studies that it can also spur better adherence to lifestyle interventions when they know they also have MASLD, but they can do something about it, particularly in the early stages. And again, while we have this big data from regions, what's the situation in your particular hospitals, clinics, cities, state, or country? Earlier this year, a group of experts that I was involved in called for a liver health check in all people living with type 2 diabetes, and published, in the Lancet GastroHep, and that's great, but this is the kind of thing where we need WHO guidance, we need national guidance to say everyone with type 2 diabetes should be tested. You just saw the prevalence data, and I'm not sure what more evidence we need than to say this is a population where I would start in terms of getting a liver test. And then, of course, if positive, there's prevention and linkage to care depending on what fibrosis stage they're at. So we know MASLD is a cardiovascular risk factor. We know there's a bi-directional relationship. But the question here is really, are there any cardiologists, at your meeting? Do they know much about MASLD MASH? Do they care? Why don't they care? But in particular, in terms of preventive cardiology, which is a great concept being rolled out in many parts of the world, do they include any liver-specific issues like MASLD screening for their patients? So all of this, really raises the issue of how well designed are our models of care. And when we reviewed the literature and looked at what's been published about more comprehensive MASLD and MASH models of care, looking at the what, the where, the who, and how of the model of care in hospitals and clinics, we came up with a set of recommendations. And one of the strongest was to use NITs, or non-invasive tests. I'll show you in a moment some data about the many different tests that are used, but we don't need to use the liver biopsy anymore. In the last 5-6 years, NITs have become much better studied. We have strong evidence. We know the sensitivity and specificity of the major tests, and some of them are quite cheap, like the FIB4. Some are more expensive. Some are available, like the FibroScan in your country. Some may be less available, but important, like the Enhanced Liver Fibrosis Test or the ELF test. And all of that requires coordination across the health system. And it's always easy for me when I go to hospitals to say, you need to coordinate better, and then I go home. But, also working in a hospital, I know how difficult it can be to get our electronic medical records aligned, to have the alerts working and to get the right people in the right room at the right time. But anyway, these are really the recommendations on what makes a more or less ideal model of care contextualized for your particular clinic or hospital. And I mentioned, there are many different non-invasive tests being used, and I think that's okay. And in this study of just 35 respondents from around the world, 14 different NITs were being used, but the real problem was that the cutoffs being used for these NITs to guide MASLD risk stratification varied between the clinicians. So it really means that people aren't following the guidance in their clinical practice guidelines or the cutoff guidance on when people should be maintained in primary care or endocrinology, or when they should see a liver specialist. We just had accepted today a much bigger version of this study with over 400 respondents, and we're seeing similar results. Many NITs being used, but not always the same cutoffs. So that's extremely important to get right, so that patients get the best care that they can. And some of the barriers to implementing these often rather simple tests is, knowledge of the NITs, interpreting how to best interpret the results, collaborations, our endocrinologists talking to hepatologists about how to use the imaging. Are they able to use the imaging? Are they able to get reimbursed for it? And do patients really even know about this, know why it's important for them to know the results and what they can do with those results. So this is a nice qualitative paper that looks at some of the barriers to NIT implementation. I realize most people in the room don't know me, but one of the things my team does is we go into the field every weekend and we test migrants, at-risk migrants, living often in precarious situations during their religious ceremonies or at community centers. And we're allowed to take a FibroScan with us, even though there's no doctor involved, and then we can link to care if needed, and they'll do another FibroScan. In some settings, you need to be a doctor to provide that kind of care, and we need to really kind of task shift. These are simple tools to use. Most of you can calculate, or any of you can calculate your own FIB4, if you have your lab results and they included liver function tests or enzyme tests. I won't really get into artificial intelligence, just to say that, we know it's here to stay. We're looking at how to use it to make many different areas in the field more fit for purpose. But in terms of MASLD, it's a great way to figure out, who's most at risk, who should be tested, and to start to predict fibrosis, which is the the real, the leading predictor of adverse outcomes and what we really want to know among our patients. MASLD and MASH are expensive drugs, expensive diseases. There are now drugs coming, and I'll come back to that in a moment, but they're expensive diseases. Studies across Europe and the US have shown, the tens of billions of dollars or euros that it can cost in both direct medical costs, but also indirect costs, or so-called productivity or society costs due to loss of quality adjusted life years. So new studies are coming. We're doing this now in 6 countries, but certainly it's something Australia could do to estimate the direct medical costs and the societal costs for 1 year or for several years, in a row. And that's the kind of thing, again, when you're advocating to policymakers, they need to see that this is expensive, it's preventable. So we need to take the action now that I know you're going to be discussing in the rest of the seminar. So essentially what you can do is you can take this framework of an investment, a MASH investment framework, and look at various costs. How do we finance the healthcare? What's being purchased? What the return on investment is? Create models, and then calculate. That's something we can also work with you on. We're doing this, as mentioned, in 6 countries now, including the US, Japan, Spain, Germany, but also Saudi Arabia and Brazil. And finding, again, it's very expensive, but we can bring down those costs if we identify early link to care and treat. The social determinants of health are also important for this disease. If you're wealthy, you are not off the hook, but low socioeconomic status is associated with a higher MASLD prevalence, a higher MASH prevalence, and higher liver cancer rates. And we know the challenges of being from a lower socioeconomic stratum and trying to get to care or trying to implement the recommendations that your doctor told you to do, like lifestyle changes, including more physical activity and better diets when you don't have the time or the money to do that. So it's important to be conscious that poorer populations will be disproportionately affected by these diseases and have higher liver cancer rates. And therefore, we've been putting forward this idea of preventive hepatology modeled along the ideas of preventive cardiology, where we look at what the components of person-centered care are, which often is around the medical treatment. But when we think about social nutrition, we can be thinking about what kinds of social support networks are there. And again, I know this best from HIV and viral hepatitis C, where they made a world of difference. We often say, the Mediterranean diet's the best diet. I mean, but you're in Australia. So what does this really mean for you? What are the components of that diet? What do you have access to, and what are relevant substitutes for people who aren't around the Mediterranean or can't afford, some of the key elements like olive oil in that diet? And then finally, what are the commercial determinants? We often blame people. This is sort of the big thing in liver disease, is it's because you're eating poorly, it's because you're not exercising enough. But we have to remember that there are strong commercial determinants that make healthy food more expensive or often inaccessible. We have food deserts, we have food swamps, and we need to be conscious of that and counteract it. And if you want, we can talk about that in the Q&A, some of the initiatives to limit the venues where lower quality of food can be sold, what's provided in schools, what kind of marketing there is, and so on. And on the left, you see social prescribing. This is a tool to link individuals with suitable non-medical resources to enhance their well-being. So what's out there in the community that we can link people to? When I worked, in the 90s and early 2000s in HIV, that really made the difference, was linking people with HIV to the kinds of housing and financial services in the community that they needed, along with peer groups. As I mentioned, there's a lot of stigma, also discrimination around these diseases. And this is from the Lancet EASL Liver Commission a few years ago. And, people often throw around the word stigma. I just want to draw your attention to, on the left, you see there's public stigma, there's structural stigma, there's also stigma in healthcare settings. And why is this important? Because it can all contribute to self-stigma, which leads to care avoidance and delayed care, increases in the number of people with severe liver disease, increases in unhealthy behaviors, a spillover of stereotypes to unrelated patient groups. And so it can have very, ultimately poorer health outcomes. So it can have really damaging consequences. And we need to be conscious of both stigma and discrimination. And really that requires a paradigm change where we're thinking about metabolic dysfunction, not just a particular disease, but really, a disease, its comorbidities, and the individual's health-related quality of life. And that's really what's been defining my work. I spent 11 years at the World Health Organization, where we worked on developing these concepts to make the health system more people-centered, which means addressing multimorbidity. And that's why I think the new name is so helpful, because it focuses on metabolic dysfunction and not just one particular disease. And it means we need both multidisciplinary, interdisciplinary, and transdisciplinary approaches. So working together in different ways, and just continuing on the food issue, because it's so intricately linked to MASLD. This is from this month's cover of Nature Review's GastroHep. And you see we focused on MASLD and food insecurity, and set out here all of the different people who need to be engaged in order to make sure that we can reduce food insecurity and identify MASLD. And this was led by Dr. Zelber Sagi, who's a nutrition and diet expert working in the liver space, and on the board of the European Association for the Study of the Liver. So what does an optimal care model look like? There are many people with many proposals. I like this one. It's from a few years ago, so it still says NAFLD, even if the first author, Maru Ranella, was the first author of the new nomenclature change. This means we're engaging with primary care providers and endocrinology. That's where we're going to find most people with MASLD. And as mentioned, you can do a simple FIB4 test or a confirmatory test there. We're going to need to engage with nutritionists and dietitians to address those lifestyle interventions, and of course with gastro and HEP practices, cardiology, weight management, health psychology are all central components. Many of those components are simply left out when we focus on just the lifestyle interventions, or just the type 2 diabetes. So it really does require a holistic approach, again, in line with a person-centered approach. So here in the US, we've had approval by the Food and Drug Administration of resmetirom for MASH liver disease. So this really represents a sea change. It's a beacon. We finally have a drug to treat this disease. It's starting to be prescribed in centers across the country, and the FDA called for it to be prescribed along with diet and physical activity. It's what I call nutrition-aligned drug rollouts. Often, people leave behind the lifestyle changes or don't provide the needed support for that, telling patients, here's your medicine, make sure you exercise and eat well. But this is where community groups and other advocates really need to push hard and say, that's not always so easy, and we need to provide support. Otherwise, we will not see a high effectiveness of this drug, because in trials, the efficacy was rather low, but enough to show a significant difference or effect, and to warrant FDA approval. And there are other drugs in the pipeline. So I think we're going to live through an era that's extremely interesting, like we did with HIV and biohepatitis C, where we see increasingly effective drugs becoming available. But in the case of MASH, we really need to address the lifestyle or the nutrition, physical activity issues as well. So when we looked at the policies that need to be in place around the world, and this included Australia, We looked at 102 countries and made an index. Do the countries have the policies that experts agreed need to be in place in order to properly address MASLD and MASH? And none of the 102 countries were prepared. Although the UK and India were really proud to be first and second, they were still under 50, so they would have failed if it was school. Close to a third of countries received an overall score of 0. We'll be carrying this out again. I hope to see some improvements. But where I think you can make a difference in your country is to look at what policies do you have in place around obesity, around alcohol, cardiovascular disease, diabetes, healthy lifestyles, and are MASLD and MASH or is liver disease mentioned in those policies? And if not, why not? I mean, how can you have a diabetes strategy or action plan and not even mention in passing liver disease when around 2/3 of people with type 2 diabetes are going to have that liver disease? So I think that's where we can engage with our clinical colleagues, with other patient groups, and start to make a step change to get MASLD and MASH addressed. I don't expect any countries, as you can see here on the far left, to have a MASLD and MASH strategy or an AFLD and NASH strategy, but it should certainly be mentioned in an obesity strategy and a diabetes strategy, yet it's often not. And in the introduction, the research and action agendas were mentioned, and they covered 6 domains. So, many of the participants were hepatologists, so we had a lot of enthusiasm around treatment and care, models of care, even some of the human and economic burden. But we also have to address the action and research we need in leadership and policies, patient and community perspectives, and education and awareness. And the final agenda includes 28 research priorities that the field defined, over 300 people from almost 100 countries, and 29 action priorities, which I know you've been looking at, and so have people in countries around the world as we try to make some change. So I won't go through them all now, just to say that we ranked them. All are important. Some were ranked as being even more important, areas around collaboration, growing networks, developing the right tools, and promoting awareness, and we've already taken a look at those. I mentioned the Sustainable Development Goals earlier, and when you look at this image on the right, you might think it's really great that they included liver in the center, but it was actually my team that made that image. We think that to achieve the SDGs, you also need to be thinking about the liver. So we carried out this large Delphi study in collaboration with the team that runs the Global Burden of Disease. So there's hundreds of co-authors from around the world, some of whom don't know anything about the liver, but are experts on the SDGs. And we ranked and studied what needs to be done. So I like 11.7 on the bottom. If you don't have safe green public spaces to exercise in, it's going to be difficult to increase your physical activity and improve your liver health. And 1.4, if you don't have rights to economic resources and basic services, how are you going to improve your liver health? So this fits very much in with Australia's commitment to achieve the SDGs. You can go into this study, you can see where Australia is ranked, and you can use that as an advocacy tool. Why are you doing better or worse than other countries, and how can you improve your score year on year? The Healthy Livers, Healthy Lives collaboration, I'm just checking the time, I think I'm still okay, brings together the 5, let's say, leading regional liver societies in order to try and end steatotic liver disease as a global public health threat and to mobilize action. And we held a side event at the World Health Assembly, which is the highest decision-making body governing the World Health Organization in 2023, and we will again in 2025. It would be great to have Australian representation. We had the Minister of Health of Brazil, the Minister of Health of Egypt, and it's incredibly important to get, as I mentioned in the beginning, that kind of top-down support where WHO starts to develop normative guidance, action plans, frameworks, and strategies. And here you see the Minister of Health of Egypt talking about their viral hepatitis program, but also MASLD and MASH. In September,
Jeff, it's a 5-minute mark.
Great, thank you. Right, thank you. I couldn't see that, but I hear you. I will start wrapping up. In 2025, we'll have the 4th high-level meeting of the United Nations on the prevention and control of non-communicable diseases. And as far as I know, liver is not only on the agenda, but no organizations representing liver health will be there. That's not the case for diabetes, cardiovascular disease, respiratory diseases, mental health. So not that it's a competition, but we are looking for equivalence with other disease areas. And there are consultations, including in your part of the world through WHO, where non-state actors can advocate for issues that should be addressed there. And this is very important because it's what will guide government responses, and it's what they will be measured against. So to advocate for that, we held a UN General Assembly MASH side event a month ago in New York City to look at a range of issues on how we can prioritize what we call the MASLD MASH global public health threat. So on the left here, you see the Minister of Health of Qatar, the Minister of Health of Mexico discussing this, and then a group of us, including Johanna Ralston, who heads the World Obesity Federation, discussing this. And the idea was to bring together many people who are not liver experts to discuss how we can get this onto the global policy agenda. And there you see we had a fiber scan so people could also see how simple it is to really figure out if you have liver disease or not. WHO does have NCD best buys. These are cost-effective and other effective interventions for NCDs. Many of them are relevant for MASLD and MASH, but none are specific to MASLD and MASH because WHO has not been tasked with doing that. We've started to develop our own, which you can see in the article on the bottom left, but this is something WHO really needs to do. We have a series of city initiatives where we carry out awareness studies among the general population, people living with diabetes, and primary care practitioners to see what they know about the risk factors, what they know about MASLD and MASH, and then we can advocate at the city level. So you don't have to just work at the country level. And then each year we run the global think tank on steatotic liver disease. It'll be in Barcelona, and it's a small curated group to really debate and discuss with a broad range of experts key issues in the field each year. Hopefully you're familiar with World Liver Day. Every day we should be advocating for the liver, but this day in particular is when you want to make a lot of noise, place an op-ed, maybe get a policymaker to speak out on the issue. So where do we go from here? I mean, we have a strong body of work from which to build, so we need to accelerate our efforts. And that means addressing not only social determinants, but also structural and commercial determinants of health, growing our community to engage policymakers, but also policy influencers and patients as stewards of change. And, we need to be working at our local level, also at the global level, and really getting WHO, our national governments, and the United Nations to take on this issue. So let me stop there and just acknowledge everyone who's contributed to all these studies. It's been an amazing process to bring together 300, sometimes 400 people to get agreement on these issues and start to set the agenda. And I'm so pleased you've taken on looking at the action agenda to see what's relevant in Australia now. So thank you.